obviously, we're going to be talking about COVID and its impact on laboratory compliance. The first thing I'm going to jump off on and talk about is me, to be honest with you. I don't know if you've gone on the website or you've gone on LinkedIn or whatever's been flying around, and you know, Jeff here has named me the lab guy, which is kind of funny in a way. It's really neat. My background is how I got here. I'm an attorney. I've been practicing for over 25 years. I'm admitted to practice in New York and Florida, and I started my career as an insurance company trial attorney. I was an insurance company trial attorney in-house for 10 years, then jumped off into doing insurance defense work. I basically switched sides and represented medical providers and sued insurance companies for reductions and denials. Fully aware of EOBs, CPT codes, ICD-9s before. So I always had somewhat of a interest and an experience in doing insurance defense in the medical background. As a trial attorney, there's two main issues in any lawsuit: liability and damages. The damages aspect always needed to be tried, as well as liability. And to do that, you were always deposing a ortho or a neuro or a chiro or a radiologist to determine what the treatment was and was it reasonable, related, and necessary. And that also exposed me to a lot of familiarity with the CPT codes, the ICD-9s, the HCFA 1500 back in the day before they changed it over to the CMS. So these are all the things that I started my career with. Then almost 10 years ago, I got the opportunity to go in-house and be corporate counsel and director of compliance with a publicly traded company that owned a series of labs throughout the country, as well as a revenue cycle management entity and an EMR entity as well. So I became fully aware with a lot of different aspects of healthcare, doing compliance and legal. And the most important thing, or the big takeaway that I have from a lot of the experience, is not from the legal side. The legal side, which is more of all the corporate documents, all the corporate contracts and agreements between employer, business associates, NDAs, non-disclosure agreements, non-solicit agreements, the leases for equipment between the labs and vendors for reagents and all that stuff, if you're doing things with Beckman Coulter, Cardinal Health, all those type of individuals. So those were all the things I was doing on the legal side, but at the same time, where I did that as well as in my role as director of compliance. And then ultimately I moved out to Texas and was the chief compliance officer for a entity out there that owned a series of labs in the state of Texas. So I have a pretty good experience with labs that were in all over the country: Florida, New Jersey, Mississippi, Texas, New Mexico, California. So I've got a pretty wide range of experience with labs all over the place. And the most important thing was I was placed in these entities because most of-counsel lawyers would tell the entity that they need a general counsel and or some type of in-house compliance program. And the bottom line, that leads me into what we call an OIG comprehensive compliance program. That program is really important. It comes down from the Office of Inspector General. It's been around for quite a while, and it really separates the independent labs on a variety of levels. The most important level is it makes sure to reduce or try to eliminate the fraudulent claims, false claims activity, any misconduct that may be occurring in the lab that the entity isn't even aware of. There are a couple main elements. We're not going to get into all 7 of a program, but the 2 big elements are education and training and auditing and monitoring. So the education and training obviously is to update or train and educate your staff when you're onboarding them, and then to regularly train them during the course of their employment. So they're staying regs that are going. The huge. I am basically giving you a compliance program based upon the impact of COVID and the rules and regs that have been waived, suspended, changed, remained in place all throughout the lab space, not only on the federal level from CMS, from the state level by the state rules and regulations, as well as the impact that CLIA may have weighed in on some of the issues that we're going to be talking about here this afternoon. So that was my background, how we're going to get started. And what we're going to do is, for the main part, we're going to talk about COVID and its impact. And I know that a lot of you have COVID testing going on in the labs, and some of you may have labs where you don't have COVID testing, which obviously originally starting going back to March, everything kind of stopped. Then everyone tried to scramble to find out exactly what needed to be done. And what ultimately occurred was a lot of labs in the commercial space figured out relatively quickly that my lab volume is crashing for the lack of people going to the doctor or to be hospitalized for non-COVID conditions, which totally decreased their volume. And the only thing, or a excellent alternative, was to ramp up or implement the SARS-CoV testing. So that's where we're at. That's what occurred between March and the present day. What actually came into effect was the CARES Act. Everyone says, we hear it knocking around all the time. What is it? It's the Corona Aid, Relief, and Economic Security Act that was implemented by the federal government back in June of this year. And basically, it talks about or refers to the requirements, the reporting requirements for labs who are doing the SARS-CoV-2 testing. Okay. Obviously, I don't know where we're at or where your lab is at in the process. This is basically a non-negotiable reporting requirement that came down from the federal government in the throes of a pandemic to try to figure out exactly what to get a fair statistical analysis, to figure out exactly how severe and significant this was. The only way you could do that is by finding out the positive rates of for SARS-CoV, i.e., so the bottom line is you have to report it. All right. What occurred was they basically gave a blueprint as to who, what, when, where, and how you are supposed to do your lab reporting. Okay, it's basically all labs. It doesn't matter if you have a temporary location or facility, if you're doing point of care or home collection. The bottom line, if you were doing testing for COVID, you needed to report within 2 days to a state or local health department, and there are obviously those requirements of the individual's residence, the location of the provider, and things along those lines, which were necessary to be done. The bottom line was to make it as efficient as they could. The states and local needed the information as quickly as possible, and that's why they were requiring the results to be reported to those state or local entities within 24 hours. We're going to talk a little greater about the concerns and what ultimately wound up occurring with lagging in turnaround times. Obviously, based upon limitations that the labs were having on the volume of testing that was being conducted, as well as limitations and bottlenecks on materials and supplies, had caused some delays in reporting. Those delays were not, put it this way, they did not go unnoticed by the state and federal entities. The CARES Act has the applicability to do the mandatory testing on the federal level. However, Florida statute has also required mandatory reporting to the Department of Health by Florida statute and administrative code. This testing or requirement was for deaths, hospitalizations, public safety personnel, healthcare personnel, individuals who are working in long-term facilities, to get a better handle of what was exactly going on in there. The requirement that the lab that performs the COVID testing is responsible for reporting to the Department of Health is important. If your lab is in the reference lab, referring lab situation, bottom line is, if you are the referring lab and you sent out your COVID because you were unable to do it yourself, then the referring lab shouldn't be doing the reporting. It's the reference lab or the lab that is conducting the test that's responsible for the reporting. I don't know what your exact situation is with what entity in the reference lab, referring lab agreement, who is required to do the reporting, but by Florida statute and administrative code, it should be the lab that performed the COVID-19 test as responsible for reporting to the state or health department, okay? There's also specifics with respect to individuals who are visiting or out of the country, and we have a lot of that here in Florida, and basically it requires those results to be reported as well. Every state is going to have its own COVID reporting policies and procedures. You need to be informed and up to date by your compliance and or legal team. Obviously, the first issue that we've been talking about here this afternoon is the reporting requirements for those labs that are doing the COVID testing. There are concerns that came up with the delayed in reporting, where Florida Administrative Code has addressed the issue and stating that the labs have got to send this data to the county health department, and they have to do it pretty quickly. And what actually occurred was, by August, I just put up a slide that CMS came up with actually a CLIA came up with an update at the end of August that addressed the issue as well. And for CLIA, they had a big concern with failure to report results. And ultimately, they said you're going to have a mandatory citation for those entities that have not been reporting pursuant to the 24-hour turnaround time. Okay, if you've ever been down the CLIA 2567 or inspections or anything along those lines, you know how difficult they are. There's specific rules in the CLIA rules and regs through the federal administrative codes, where they have those D1002 and D3000 violations. There's different levels of violations, and the CMP, which is a civil monetary penalty that CLIA can impose on you. So these things are out there. These are all, the whole carrot and the stick. These things are incentives and requirements to make sure that the labs that are doing the COVID testing is being done in a quick and efficient turnaround manner. Obviously, if you see on this statute up here, the first day you're not in compliance is $1,000. Each additional day, it's $500. So obviously, the penalties could add up rather quickly if you're not in compliance with the CLIA rules and reg that went into effect in August of 26. And actually, what happened, guys, I think the Florida people will remember this, and I'll go on to the next slide. Is in Florida, what happened? I think it was Quest held tens of thousands. I forget the number off the top of my head, and then basically would do a data dump at a later date, and it would skew the numbers from the state that was reporting the daily positive rates, and all of a sudden they would get an additional 10 or 20,000 results all on one day that were basically 1 week, 2 weeks, or even greater delays in reporting that were skewing the numbers. So the pushback from the governor was to submit or implement an executive order that occurred on September 11th of 2020, requiring labs who haven't reported within 7 days from the test that they can't even do it through the HL7 system. Okay, so the requirement was based upon the concern that the state of Florida had with the failure to report the timeliness of the COVID. If you think about it, it kind of makes sense, guys. If somebody tests positive, you want to know ASAP, as quickly as possible, what the results are. Think about what was initially going on and currently still going on. You don't know if you tested positive. You're not exactly sure. Should you be isolating? Should you be quarantining? The impact it has on school, with your employer, with your family, with your friends. So all those things were, if the report wasn't getting done quickly, it had a huge trickle-down effect on everything which was occurring. There was a huge pushback all on the state level, all on literally by the county and on the city level and every entity. And it's still currently that same way today. So the bottom line is the turnaround times were a huge issue. I'm going to get into this later on in the presentation, where CMS has made a decision based upon the turnaround times and how it affects rate of reimbursement as going forward as of January 1, 2021. Okay. So the situation with lab reporting, obviously, based upon the pandemic, without the labs providing the daily results to the municipalities or the Department of Health or all those regulatory agencies. That was number one. But also what's getting lost in the fact is HHS, the Health and Human Services, also said, hey guys, by the way, you really should be reporting these results to the ordering physician, and you should be providing the results directly to the patient by mail or email or through your patient portal. So all of the labs out there, guys, this is a common sense thing. Obviously, you've got the patient portal. You know, you've got to communicate the results to the testing, to your ordering provider, and to the patient. Obviously, HHS on the federal level has made this a recommendation and not a requirement, but you also need to be aware of there is a parallel reporting version or requirement on almost everything that we're doing that's on the state level. So it may be just recommended on the federal level. That doesn't mean that it may not be required on the state level, because a lot of the state rules and regs and statutes have not been waived or suspended like a lot of the rules and regs that we have seen on the federal side. So that's the important takeaway that is occurring with respect to the reporting on the COVID testing itself. Okay. The next situation, or the area that I want to address, is the HIPAA concerns regarding the reporting of the testing. Okay. The bottom line is, we all know HIPAA. All right, it's basically the Health Insurance Portability and Accountability Act. Everyone always types it as HIPAA, but it's a kind of a pet peeve of mine, guys. Make sure it's HIPAA. Okay. If there's one takeaway that we can have from today, let's make sure our abbreviation from HIPAA is correct. All right. The HIPAA. Here's the bottom line with HIPAA. There's basically a restriction from disclosing PHI, which is personal health information, to entities without the consent of the patient. The big thing with HIPAA we need to be aware of, there's a lot of misnomers, okay? HIPAA applies to covered entities and their business associates. Covered entities are basically healthcare providers, entities that are considered healthcare clearinghouses, and health insurance companies. We read every day where in the newspaper we see it a lot, where somebody disclosed personal health information of an individual, and everyone is screaming, "Oh my goodness, they're violated my HIPAA rights, and I'm going to go make a claim, and I'm going to either sue you or do this." But the bottom line, guys, if you're not a covered entity, i.e., for the most part, an insurance company or a healthcare provider or a business associate, which is somebody that has an agreement, that's a vendor doing work on the provider's behalf, be it a IT entity or something like that, and they enter into a business associate agreement with them, it's not applicable to your employer and other individuals. Okay, so screaming that the HIPAA, my HIPAA rights are violated, depending on who exactly disclosed the patient's protected health information, will determine whether it is actually a HIPAA violation or not. And there are the three big exceptions are TPO. That's how everybody remembers it at HIPAA, which means for treatment or for payment or for operations, you don't need the patient's permission to disclose their PHI. Perfect example, if you have a consult and you're an ortho and you need to refer to the radiologist, you don't need the patient's permission to have the MRI results provided back to you from the radiologist. You don't need the patient's permission to submit the bills to insurance companies that contain the patient's PHI, because the bottom line is we all have to do a submission of documents to support medical necessity, and obviously all of those documents to get reimbursed contain PHI. So those are the big three payment, treatment, and operations. But the other big exception there is for a public health situation. It's a common sense thing when something's going on, like in this case, clearly, which is a pandemic, that the federal government is going to jump in and say, hey guys, this is a situation where you need to report. As a matter of fact, if you look specifically at the HIPAA statute itself, it also is going to tell you that there is a exception for public health, and that's exactly the situation that we are currently under now. The Office for Civil Rights literally came out with a waiver of potential penalties for HIPAA violations against providers who are serving the community through technologies for COVID. The bottom line is, if you think about it, everybody was afraid to go to the doctor. Most people started doing it by FaceTime or Skype or whatever, Zoom or whatever entity they had. And the situation with FaceTime and Skype, a lot of these technologies were not HIPAA compliant. Usually you need a VPN and certain things like that. And those methods or those communication technologies were not HIPAA compliant. Obviously, the federal government jumped right in and said, hey, obviously you're not going to be able to get these people in your office. It's not safe maybe for symptomatic individuals to be in your office. Let's start doing this all by telemed. Okay, and that's the big jumping off point here with respect to HIPAA, with respect to telemed. Not only did the HIPAA statutes have restrictions with respect to that communication technology, so did the Florida statute. So the bottom line is the Florida statutes, for the most part, have not been waived or suspended for most of the situations involving COVID. Specifically, you could go through the executive orders on the governor's website, and you could literally, they get updated on a daily basis, which your team should be doing. But for the most part, the Florida statutes are still in place and haven't been waived. A lot of the federal things on the OIG and the CMS level have waived and suspended things, like I said, like the HIPAA requirements. But you have to be careful to make sure that you're still in compliance with the state statutes. Okay, and that's specifically, we're going to get onto a different topic here, and that's the COVID and the patient financial responsibility waiver. Okay, bottom line, the waiver of copays and deductibles. It's a big thing. It's been going on in Florida and all over the country for years. It goes back to the Anti-Kickback Statute, which was in the federal government has the Anti-Kickback Statute, and they've deemed that the waiver of patient costs and sharing amounts as an inducement, okay? And that inducement is, hey, you're not using my lab or my services because I'm a good lab. You're using my lab because I am waiving the patient's financial responsibility. It's been deemed an inducement going back to an OIG Special Alert back in 1994, okay? Obviously, you can have a waiver of a patient's financial responsibility, but it needs to be on a financial hardship and a case-by-case basis. You just can't put in your file that the patient claims that they're in a financial hardship. The insurance companies are out there. The insurance companies are looking at waivers of copays and deductibles. Insurance companies, if you are claiming financial hardship, needs to be documented. It needs to be in writing. Your revenue cycle management team, your third-party billing company should have policies and procedures with financial hardship and what documentation needs to be prepared in order to be in compliance with the insurance company's responses to proof of financial hardship, as well as to make sure you are in compliance with the anti-kickback statute. With respect to that, in March of this year, the OIG implemented a statement policy that basically has waived the patient responsibility requirement for copays and deductibles with respect to COVID. Think about it, guys. It's pretty simple. It's common sense. They want people to get treated to prevent the spread of COVID. They do not want people to not go to a provider to get tested because they are concerned about the cost to them to get the testing or the treatment. So that is what has been occurring with respect to the cost sharing waivers by the federal government and CMS. The Medicare Advantage, which is the Medicare programs that are run by the insurance companies, have also chimed in and have also waived the patient financial responsibility on copays, coinsurance, and deductibles. The OIG has stated that the waiver of cost sharing by Medicare Advantage carriers for COVID lab tests satisfies the safe harbor to the federal anti-kickback statute. But remember, guys, in addition to the federal anti-kickback statute, there are also applicable state provisions that have not been waived. So just be very careful with respect to the waivers of copays and insurance. This is one that I do not think that the state will be actively pursuing if you are basically in compliance with the CMS rules and regs regarding the waiver of copays and co-insurance. A lot of the commercial carriers also have chimed in, and they also have their own specific policy provisions about waivers of patient financial responsibility. There are some things that are still in effect. The business referrals with respect to a kickback, there's still kickbacks out there, which is labs offering value for referral sources or anything from the lab. Obviously, that's still a violation. And there's also the Florida statutes that are still in effect regarding the prohibition of lab personnel in the ordering provider's office. That's still in there. They changed where it's located in the statute, but it's at 456-054. It's still in there. Other states may allow lab personnel in the provider's office. However, it gets tricky. If you're out of state, please be careful. Once the lab personnel start doing tasks that are deemed to be appropriate for the provider staff and not related to specimen collection, it's going to be deemed to be an inducement. So that's always out there. So be really, really careful on that front if you could. This is obviously CMS has literally authorized a waive of financial of responsibility of the patient's responsibility. We talk about Medicare Part A, Medicare Part B. A is for hospital treatment, B is for outpatient services, and they have specifically mandated that all tests covered by Medicare, Medicare Advantage, and private Medicare insurers is waiving the patient responsibility. So it's also waiving it for other things as well. Telemedicine visits, hospital admissions may vary. So here's where you really need to have your insurance verification team jump in. Each carrier is different. Each carrier has start dates and end dates with respect to waivers. So don't be surprised if you have been getting paid or your third-party biller has submitted invoices to your patients where the patients may be saying, hey, has my responsibility been waived and I paid you my $20 copay and can I have it back? That stuff is going to be out there. It needs to be addressed. You need to have a good relationship with all your patients, and you need to really update your insurance verification team, your revenue cycle management team on this issue, because you may be responsible to reimbursing patients. Florida statute also chimes in with respect to deductible. There's a specific statute that requires and prohibits the waiver of the patient's copays and deductibles and requires a good faith attempt to collect the deductibles. Good faith attempt is always an issue, and it has been in Florida. Good rule of thumb, if you have a patient's address or the insured's address, which could be mom and dad, you should be sending the bill there. Good faith attempt to collect. It's not by code or statute. Do you send one bill and then follow up with 2 or 3 bills at a later date? Well, I got to tell you, if you want to be in compliance, I've seen the carriers, specifically here in Florida, requesting proof of the lab's good faith attempt to collect. The bottom line is, speak to your revenue cycle management, your legal, your compliance individuals out there, and make sure that you have the written policies and procedures regarding what you're going to do to be deemed your good faith attempt to collect the patient responsibilities, not only for what has been going on in COVID, but for every test that you have been performing. So that's the big takeaway with respect to waivers of copays and deductibles. The bottom line, it's dual track. It's on the federal level. It's on the state level. But CMS has certainly encouraged people to receive treatment. And one of the big ways to incentivize that is by taking away the patient's financial responsibility during the pandemic. A couple of the lab updates or CMS updates that have occurred. What was occurring was you didn't even need a rec form signed by or an order, I mean whether it was signed or not, to go get a COVID test. CMS said, or I'm guessing they were auditing the total amount of people who were getting multiple COVID tests, and as of August 25th, they indicated that they will cover the first test without an order, and then a physician or practitioner ordered is going to be required. Kind of makes sense. When we talk about the documentation to support medical necessity, well, if there was never an order required to get a COVID test, there's certainly no documentation. So prior to August 25th, you didn't even need documentation to get reimbursed from Medicare. The insurance companies, it's a case-by-case basis. In your experience, you'll see what's going on, what they have and have not been requiring with respect to frequency, with respect to rates of reimbursement, what they're going to be doing now, what they're going to be doing in the first of the year. You need to totally be up to date on it. The concern I know that a lot of out-of-network labs have is they're not getting the latest policy provisions from the carriers because they are not in network, and they're always a little behind in the latest policy provision and updates regarding frequency and rates of reimbursements and the medical documentation requirements. Going back even earlier, we talk about the Stark requirements. Stark, guys, is the Physician Self-Referral Act, but the bottom line is CMS figured out really quickly that doctors who owned entities that they were referring their patients to certainly seemed to refer them at a much greater rate than they did to refer them to entities that they did not have a financial interest in. Perfect example, an ortho or a neuro owning an MRI or a CT scan firm entity and sending all of their clients for MRIs and CT scans. So that has been deemed a violation. There are specific exceptions to the self-referral provisions of STARK on the federal level, and there's also provisions on the state level regarding referrals. So not only does the federal government have limitations with respect to patient self-referrals, Florida has what they call the Patient Self-Referral Act, which came back in 1992. It's at Florida Statute 456-053, and that also prohibits a provider from referring a patient to an entity where the provider is an investor or has an investment interest in it. Kind of makes sense, guys. You really shouldn't be sending patients to an entity that you own. So there are obviously some exceptions to that. I'm not going to get into that here, but you could speak to your compliance and legal guys on that area. Next area I want to talk about is the infectious disease respiratory pathogen panels and what's been going on in the lab space. Very recently, I think it was on October 15th, that in light of flu season that is coming up, the question is, do I have the flu or do I have COVID? The symptoms are very similar: the fever, the chills, runny nose, headache, fatigue, and it's very difficult without a lab test to determine whether you had the garden variety influenza A or B or COVID. And obviously the ramifications of differentiating the diagnosis is extremely important. So what occurred was instead of just going for a COVID test and coming back positive or negative, if it came back negative, but you're still symptomatic, the concern is, was the test wrong? And do I still have it, or what's going on? And so what the labs were trying to do and did do was come up with a revision of their respiratory pathogen panel to add COVID to their RPP panel that already included the numerous other COVIDs as well as influenza A and B. So the bottom line was the AMA took it up. They've added two specific CPT codes, 87636 and 87637, which are now the codes that allow the respiratory panel to include both COVID and the influenza to be tested at the same time. Now that obviously we're in cold and flu season, in combination with COVID, this is exactly what should be going on in the lab space. I think the obligation of the lab is to give enough information to your ordering providers to tell them that the ability is out there to order this respiratory pathogen panel combination. I know a lot of labs have been trying to scramble to add the combo respiratory pathogen panel of COVID and flu. It's out there. It sounds like a really good business decision and a healthcare treatment decision to combo these two tests into one, and the AMA and also has agreed to it. Okay, that's the good news. What also needs to be made aware of is the CMS has chimed in with respect to the concerns of turnaround times. The high throughput COVID test is getting reimbursed for right around $100. However, as of January 1, in a October 15th announcement, CMS has basically said, you know what, we are reducing the rate of reimbursement from $100 to $75. If you want to get paid $100, you need to provide the test results within 2 days from when it was taken from the patient. And they have a couple of hoops that you jump through, and if the lab test takes longer than 2 days, you're only going to get $75. They are requiring a specific additional CPT code that needs to be added. I'm thinking that currently a lot of the people are using the HCFA code, the U0004 code, and if you want to add on the $25, you're going to have to add the U0005 code to it. I've spoken to some third-party billers, and they definitely have a question with respect to the condition that the majority of tests have got to be within 2 days for all patients, not just Medicare patients in the previous month. And do you now have to hold all your billing for 30 days to make sure the majority of all tests were performed within 2 days? I don't know if that's a good business decision. I know that on the CMS 1500 form, you now should be separating for all dates of service after January 1 to 2 separate CPT codes or HCFA codes, one for $75, one for $25. You're going to have to talk to your revenue cycle management people about how you're going to revise and amend the billing, and then how to also audit and monitor for the turnaround times for the testing of all patients and not just Medicare patients. This is exactly what I'm talking about, going back to the comprehensive compliance program that's needed. I talked to 2 main elements. This is the education and training that we're literally doing now as part of this webinar, and the other is the auditing and monitoring. This is exactly an audit and monitoring situation that needs to be done by either your revenue cycle management people and then reported on a monthly basis, probably weekly basis, to your compliance team to make sure that you're in compliance with it. So there's a lot of hoops that everyone needs to be jumping through to make sure that we're all in compliance with all these new rules and regs that are currently out there. The whole big issue as well with respect to all these new CPT codes is you can surely anticipate delays from Medicare and commercial carriers as they update their systems. The concern is rejections and denials. You're going to have to look to your local MACs, the local Medicare administrative contractors here in Florida. It's First Coast. You're going to have your insurance verification team to contact the commercial payers to say, hey, how do you want me to bill now for these new CPT codes that are combining the COVID test with the other tests in the RPP panel, and as well as the $75-$25 reimbursement split as of January 1 of 2021. These things will obviously keep your team busy and gainfully employed in going into the future. There are some concerns going forward too. I mean, matter of fact, last month, the National Independent Laboratory Association sent a letter to the Whitehouse Task Force where they had huge concerns with respect to supplies and distribution and exactly what was going on. It's great if you have the volume. It's not so great if you do not have the supplies and the testing personnel to conduct the testing efficiently and quickly, to have that 2-day turnaround time that's required. I know the one lab said we are capable of doing 3,000 tests a day, but our vendors have basically been only able to provide us with enough supplies and equipment to run 500 a day. I know there's a lot of bottlenecks out there. I can't imagine the ramping up that's been occurring in the lab space with all the lab vendors with respect to test kits, pipettes, reagents, and everything. You guys are out there on the front lines. You see it every day. Obviously, I'm somewhat aware of all the day-to-day ops that's going on in the lab world, and I know this has got to be a big concern to everybody. NILA obviously is making this their priority. I don't know what the solution is, other than everyone's trying to ramp up production going forward. Obviously, for now, everyone's been doing the antigen test. That's part of that respiratory pathogen panel, but there's definitely issues out there with respect to bottlenecks that are occurring in the lab space, and also with personnel. I'm sure, you know, your techs and stuff are busy as they've ever been. You're going to have to be very careful with respect to the staffing component as well. I think it's limited as well. It's another limitation, and it's another stressor that's on the lab space. Going forward in 2021, not only what we have to remember of is the antigen testing that we're doing, is that a vaccine is going to come out, and it's going to be out probably sometime next year. And the question is the effectiveness of the vaccine and the impact that's going to have on the lab space. And my opinion is it's another thing that labs need to be aware of. I don't know if you guys out there are currently doing the antigen test as well as the antibody test. The antibody is obviously a blood test that you can add to your blood, your chemistry. I don't know what panel it falls under. But a lot of people who are going to get the vaccine, and as the pandemic continues to continue, are going to want to know what their immunity is. And the only way to determine that is by the antibody test. So going forward, consider adding the antibody test to your test menus. The antibody test is out there. There's a specific CPT code for it. A matter of fact, in August, there's been a couple additions to the CPT codes. I know 86318, 86328 are out there. They've added a couple new codes, 86408, 86409 for a neutralizing antibody screen, and another methodology for the antibody test. These things need to be considered, guys. You need to be talking to your stakeholders about adding this to your current test menu. Think of the interest that employers, healthcare facilities, schools, I have them up on the screen, nursing homes, assisted living facilities, a lot of individuals or in the day-to-day activities are going to want to know, are individuals immune? There's questions of legal questions of the requirements of an employer requesting an employee to know if they are, if the vaccine was effective and things along those lines. All these things are going to have to be worked out. All these issues are going to be things that you need to discuss with your healthcare compliance and legal team. And that's how I am going to wrap up this webinar. Thank you so much for allowing me to provide all of these issues and topics to you. And just make sure if you have any questions, please feel to reach out. You know where I am. I'm obviously on the internet. You can just give me a call. I'd love to help you if you have any questions with respect to lab compliance and lab legal issues that you may have currently experienced as a result of the pandemic, or things that are in the best interest of your lab going forward for 2021 to make yourself the best lab and the most compliant lab that you could be going forward. On that note, guys, thank you very much, and I appreciate all the time and attention that you've given me, and give me some feedback. Let me know what I did, what I didn't do, what you think I should be doing in the future, what type of areas or issues that you may want me to present on the future as well. Thanks, guys. Appreciate it very much. Have a great afternoon.